we have a doyen of pediatric orthopedic and particularly the foot problem in children's with us, Professor Vincent Mosca. Actually, he does not need introduction to this gathering because he had been to 3 times before to this meeting, and he has been to India 5 times for various meetings. He's Professor Emeritus of Orthopedics at University of Washington and Seattle Children's Hospital. And his major contribution is, I would say, the Mosca's procedure. That's the lateral column lengthening. Almost all of us are doing this procedure. And he's the person who described this method for the first time. In addition to that, his another contribution is his famous book on pediatric foot problems. We all have seen the first edition, and now the second edition of the same book will be available in July this year. So with this short introduction, now I request Professor Hitesh to tell us something about why this topic is important for all of us. Over to you, Hitesh.
Good evening. Thank you, Dhiren bhai. It's our pleasure to have Dr. Mosca because he is authority of pediatric foot and ankle. And today we are going to discuss the very important topic is rigid flat foot. The commonest reason is the tarsal collagen, but there are a lot of controversy in management of the tarsal collagen. So it is very important to know what are the variables to be considered, how to examine the patient, because the tarsal collagen flat foot might be rigid, but painful or painless. So pain might be related to the excessive mobility or the instability or pain. So it is very important to do the very important clinical examination as well as the management. And there are a lot of controversy regarding the management, either go for complete fusion or do about excision. So we are fortunate to have it. Over to you, sir, for the rigid flat foot. Thank you.
Thank you, my very dear friends, and you are my dear, dear friends. I'm so pleased to have been invited to speak with this group again. Having, as Dr. Ganjwala mentioned, having been to India 5 times, I feel very good closeness to the people of India, my friends in India, to India, the country, the amazing country. So I'm pleased to have had this opportunity to talk with you. And last week, as you recall, I spoke about flexible flat foot and talked in a way that hopefully dispelled a lot of the myths, a lot of the misunderstandings that flexible flat foot is not a deformity. It's actually a normal foot shape. I also mentioned last week that in the famous studies by the Canadians, Doctors Harris and Beath, in the mid-1900s, they found that about 23% of young adults in Canada, soldiers, about 23% had flat feet. 2/3 of them had flexible flat feet. And that's when they showed and proved that flexible flat foot is both common and normal. They found that about 24% of the 23% of flat-footed Canadian soldiers had the same flexibility of the flat feet, but they had tight Achilles tendons. Those soldiers, that smaller group of the flexible flat feet, often had pain. And then the smallest group that they identified of the flat-footed Canadian soldiers, about 9% of the 23% of flat-footed Canadian soldiers had rigid flat feet. And that's what I'm going to talk about today. That group, 9% of the 23% of soldiers, adults, who had rigid flat feet, not flexible. Oh, there we go. No conflicts. So that's the group I'm going to talk about. It's a small percentage of the total. So actually, how many people have rigid flat feet? A lot of the older literature said that it was between 2 and 5% of the population. So I've given you a lot of numbers. I said Harrison Beath said 9% of 23%. That's actually about 2 to 5% of the total population of people who have rigid flat feet tarsal coalitions. What Harrison Beath further identified was of those Canadian soldiers who had rigid flat feet, they were able to use x-rays to identify tarsal coalitions in 88% of them, meaning that there were 12% of their rigid flat feet that they could not identify tarsal coalitions. That's a separate group, and it's such a complex topic because it's so rare, it's so not understood that there's no good literature on understanding that small group. Again, rigid flat foot without a tarsal coalition. We know very little about it. I'm trying to do some studies with some other colleagues to see what we can, if we could shed any light on this small group. But because it's so not understood, it's not misunderstood, it's not understood, I'm not going to talk any more than to say, when you see a child who has a rigid flat foot, you have almost a 90% chance of identifying a tarsal coalition and a 10 to 12% chance of not finding a coalition. So stay tuned on how to evaluate and manage those. Hopefully in the next year or two, there'll be more literature, but for now, we know very little about them. Let's go back to the 88% of rigid flat feet that have tarsal coalitions. They're primarily autosomal dominant. So siblings may have it, parents may have it. It's typically autosomal dominant. And it's actually not 2 to 5% who have them. There are some cadaver studies and bone studies that indicate perhaps up to 13% of human beings have tarsal coalitions. They may be in the most common locations, which are between the calcaneus and the navicular, or between the talus and the calcaneus, the so-called subtalar coalition. But there are many others throughout the foot, between the cuneiform bones, between the navicular and the cuneiform. There can be many others, but most of the coalitions are between the calcaneus and navicular, which you can see an example in the upper right, that looks like a narrow, irregular, maybe almost like an arthritic joint. There should be a black space there. Those two bones should not meet each other at that location. And the other most common type is between the talus and the calcaneus in the subtalar joint. You can see in the bottom right on that CT coronal image that a joint should look like the posterior facet on the right side of the image. It's got smooth subchondral margins, thick cartilage space, homogeneous, whereas the middle facet is downsloping. It should be horizontal. The subchondral bone is irregular. It's not smooth like in the posterior facet on the right side of the image. And it's narrow. Again, not as thick, not as smooth. That's a coalition that, if you know what you're looking for, you know that's a coalition on a CT scan. You do not need an MRI to say that that's a coalition. In my talk last week, I mentioned how CT scans are the advanced imaging when looking at and evaluating foot deformities, not MRI. That's a coalition. That's what they look like. Coalitions are bilateral in about half the cases, and sometimes it can be more than one coalition per foot. So a child may have both of these in the same foot, or one of these and one at another location. All right, so 13% of the population, that's about 1 in 7 to 1 out of 8 people has a tarsal coalition. 1 out of 7 to 1 out of 8 human beings are not in pain, nor do they have functional disability. I mean, can you imagine if 1 out of 8 human beings had a problem that needed management, especially surgical management? Orthopedic foot surgeons couldn't do anything else in their lives. They'd have to be treating these all the time. 1 out of 8 people. So obviously that can't be the issue. The issue with tarsal coalitions is that some affected individuals have pain. And if they have this activity-related pain, because that's when it occurs with activities, it sometimes is experienced between the ages of between 8 and 16 years, rarely in younger kids. And if they're going to have pain in their lifetime, it generally starts in that interval between 8 and 16 years of age. These are more examples of the calcaneonavicular tarsal coalition. You can find this quite easily on the oblique X-ray, just the standard. You order standing AP, lateral, and oblique X-rays. This is the oblique that you get, and you can look right down on this view and see the fibrocartilaginous, not ossified coalition. Or you may see one that's completely ossified. And the pathophysiology of coalitions is that with the autosomal dominant inheritance, they're programmed to have two or more bones coalesce, joined together. They're not solidly coalesced at birth. And that's so different from some other congenital synostoses. All right, so these are synostoses, joining together of bone. But the joining together of bone is not present at birth. It's programmed to happen, but it's not present at birth. There are other coalitions I'm not going to talk about today in which the two bones that are coalesced were never separate. They were always a synchondrosis that became a synostosis. That's a different group. But in these, there's fibrous tissue between the bones at birth. It undergoes metaplasia to cartilage, as you see on the left, and eventually onto bone, as you see on the upper right. So it's an interesting pathology because they were not solidly together at birth, and then they become so. If you look at plain X-rays, then beyond that, you can look at the AP X-ray, and if you look to that side, you can see there looks like there's a dark line, hard to see, so the AP doesn't help very much. The oblique is diagnostic. And if you look at the lateral X-ray, you can see the so-called anteater's sign. An anteater is an animal with a very long snout, and they eat ants. They're large mammals, but their main diet consists of ants. So they have these long noses that look pretty much just like that connection between the calcaneus and the navicular. So some person decades ago called this the anteater's sign that you can see on a lateral X-ray to give you a suggestion that there's a calcaneo-navicular tarsal coalition. I said earlier that sometimes that there's sometimes more than one coalition per foot. So if you see these X-rays, you say, okay, clearly calcaneo-navicular coalition. But you want to make sure that that's the only one, because if you're going to manage it, particularly surgically, and you remove one coalition and not the other that coexists, the child might not be any better because you didn't really address the pathology. So when you see this one, you got the plain X-rays, no advanced imaging, it's hard to see a subtalar coalition on plain X-rays. In the lower right, you can see a so-called Harris view. And if you look carefully, that's the middle facet. It looks clear, it looks normal, it's horizontal, it's thick, no subchondral sclerosis. But the Harris views are really often blurry. So the definitive way of finding that coalition, or any of them, is with a CT scan. On the top row, you can see different slices revealing the calcaneo-navicular coalition in different planes. In the lower left, you can see 3D reconstruction, again, confirming the pathoanatomy. And there on the coronal images on the lower right, you can see that's a healthy middle facet, no coincident subtalar coalition in the foot with a known calcaneo-navicular coalition. But you must, when you see a calcaneo-navicular coalition and you're going to start managing it, before performing surgery, if that is what you're going to do, you must get a CT scan. Absolutely must get a CT scan in all three planes, transverse, sagittal, and coronal, and with the 3D reconstructions to rule out a coincidental subtalar coalition. As for the talocalcaneal coalitions, there are certain features that you can see on plain X-rays, but not as clearly, and you certainly can't see the subtalar coalition as well. In the right image, that looks like a coalition because the middle facet is down sloping. It looks kind of narrow, but you don't have much to compare it with. It's sclerotic, but in the day before CT scans, that was the best one could do, was get the Harris view. On the left, you see the so-called talar beak, that spike of bone dorsally on the head of the talus, which originally Harris and B thought was an arthritic spur. It's not an arthritic spur. It's a traction spur created by limitation of subtalar motion, and the talonavicular joint capsule gets stressed repetitively and forms a dorsal spur. So it's not an indication of arthritis in the talonavicular joint. It's an indication that the talocalcaneal subtalar joint is not moving, and that puts stress on the talonavicular joint. So subtalar joint can't move because of the coalition. Talonavicular joint capsule is stretched, causes a traction spur on top. That's what the spur means. And then you see the yellow, looks like the letter C. So the C sign described by a doctor named Latour, the C sign of Latour is a suggestion that there's a subtalar coalition. The subchondral bone of the dome of the talus, so just in the dome of the talus and the ankle joint, there's subchondral sclerosis. That's normal. Under articular cartilage, the bone, before it becomes cancellous, is slightly a white shadow. Well, you follow that white shadow, the dome of the talus, posteriorly, and there should be a black gap between the talus and the calcaneus in the middle facet. You can see that line is continuous posteriorly. And then that line goes under the sustentaculum tali, the middle facet. So when you take those three subchondral lines and also the connection between the talus and the calcaneus, it looks like the letter C. It's pathognomonic of a subtalar coalition. It's not always there, but it's almost always there. And it's an indication or suggestion when you're examining the child in the clinic. You send the child for the x-rays, they come back with the x-rays, you get this image, and you see what looks like a C sign of Latour, with or without the dorsal talar beak. And maybe you could see something on the Harris view. It says, yes, I'm going to send this child for the definitive study, which is the CT scan. And then you get these images. On the lower left, easy to see, which you could barely see. I'm going to go back here. So look at that Harris view, because that Harris view is showing the same thing that's lower left coronal image on the CT shows. But there, you see the downsloping. You see the subchondral sclerosis. You see all the narrowing, all the things that say that's a middle facet fibrocartilaginous tarsal coalition. With the CT, you can also see it in the sagittal view. You may be able to see it in the transverse, but not always. And then with the 3D reconstructions, you can take that image, you can spin it horizontally, vertically. You can look at it in so many ways and see not only the surface appearance of the coalition, but also the shape of the foot. So you've done your examination, and we talked about this last week as well, you examine the foot, you find limitation or no subtalar motion. The child goes into toe standing heel raise, and the valgus hindfoot persists and does not invert to neutral. You have the too many toes sign, and you may be able to find some point tenderness as well. But they're coming in not because they were told that their siblings have a coalition, but they're having pain. Not all have pain. A small percentage have pain, but some have pain. You find on exam that it's a rigid flat foot. You get the x-rays that day. You have either evidence or suggestive evidence of a tarsal coalition, and then you will eventually send them for advanced imaging, the CT scan. But meanwhile, you need to specify where is the pain. One of the principles I talked about last week was it's not enough to ask the child or for the child to offer the fact that they have pain. Where is the pain? What brings it on? What makes it better? What makes it go away? Those questions have to be answered. You can't just go with foot pain and I see a coalition on an x-ray. They may not be related. Well, as far as pain goes with coalitions, there are several different locations pain can be located. One is that pain can be at the coalition, but only if it's still cartilage, syndesmosis, or only if it's fibrous tissue, a syndesmosis, or cartilage, which is a synchondrosis. And that may be, so in the lower left, you see I pointed at the middle facet, which could be the site of pain if it's still fibrocartilaginous. Or there can be pain on the upper one right over the sinus tarsi at a fibrocartilaginous calcaneonavicular coalition. Or the pain could be at adjacent joints, subtalar coalition in particular, but calcaneonavicular coalitions also will cause restriction of subtalar joint motion. So if the subtalar joint does not move, the adjacent joints try to move farther than they normally would. And that can cause stress transfer and eventually degenerative arthritis in those adjacent joints. What's adjacent to the subtalar joint? Chopart joints and the ankle joint. Well, I'll just say categorically that kids, adolescents, may have stress transfer to those adjacent joints, ankle and Chopart, but they never have degenerative arthritis. They haven't walked enough. They haven't lived long enough. They can have stress transfer, but not arthritis in those adjacent joints. Adults, on the other hand, could. So it might be the ankle, might be Chopart joints. The third place that someone with a tarsal coalition may have pain is related not to the coalition, but to the flat foot deformity that's usually associated with a tight Achilles tendon. So that may be pain under the midfoot or in the true sinus tarsi. Well, what does that remind you of? I said last week that individuals who have flexible flat feet and tight Achilles tendons will sometimes report pain under the medial midfoot, under the talar head, and impingement type pain in the sinus tarsi. Well, that's flexible flat foot with tight tendo-Achilles. Rigid flat foot with tight tendo-Achilles can have the same sites of pain, those two locations. So whether the subtalar joint is flexible or rigid, there can be pain from the deformity the deformities themselves, which are flat foot, tight heel cord. Again, just like flexible, but this time it's a rigid flat foot with a short heel cord. So 3 potential reasons for pain at the synchondrosis of the coalition, or stress transfer to adjacent joints, or pain related to the deformity under the midfoot and in the sinus tarsi. When we're thinking about our algorithmic approach to management, besides what the x-ray looks like, despite what the CT scan looks like, and your physical exam, you have to, not despite, you also have to note where is the pain. So you choose the right of the several treatment options. And recall that bony coalitions, whether it's the middle facet or the calcaneonavicular coalition, once it becomes solid bone, it cannot hurt. A solid coalition cannot be the site of pain, any more so than a fused joint can. You know, in the days before total joint replacements, if you had terrible arthritis of your hip, terrible arthritis of your knee, terrible arthritis of your ankle, the treatment to stop the pain from the degenerative arthritis was to fuse the joint. If a joint is fused solidly, it cannot hurt. So whether we create the joint fusion or is created because of the pathology, in this case, a coalition, once it's solid bone, that cannot be the source of pain. It can only hurt if it's still fibrocartilaginous. Just remember that. And this aspect of evaluation of a child, adolescent with a rigid flat foot and tarsal coalition is probably one of the most important assessment features. Where's the pain? So when do I treat tarsal coalitions? Well, I treat them when I cannot relieve the activity-related pain after all efforts to relieve the pain. Because the goal is to relieve the pain, not necessarily to remove the coalition. So we treat only the symptomatic ones, non-operatively and maybe operatively, but we only treat the symptomatic ones because of this classic study by Leonard in 1974. And nobody's ever refuted this. He found that only 24% of affected individuals, those who have tarsal coalitions, only 24%, 1 out of 4, had pain. And not just among adolescents, but in an individual's lifetime, an individual who has a tarsal coalition, in that person's lifetime, there's only about a 24% chance that there will be pain. And if there's no pain, there's no problem. Because pain is an indication that there's a problem. So if there's no pain, there's no problem. Got maybe 13%, maybe 5%, but a lot of individuals with coalitions, most of them don't hurt, will never hurt. It doesn't seem to matter that the subtalar joint doesn't move very well in those individuals. The thing that I've struggled with for my whole career is to understand why, if you're born with or develop a coalition and no subtalar motion, you have a 75% chance of doing well. Whereas if I fuse the subtalar joint, then odds are you're not going to do well. That if I fuse the subtalar joint alone or perform a triple arthrodesis, the ankle joint will almost definitely become arthritic later on. So not the case if you have a coalition, but it is the case if we as surgeons fuse the subtalar joint. And what about trying to convert the small percentage of painful coalitions, converting them into painless coalitions by non-operative measures? No one ever died from a coalition. So if you take the time to restrict activities, maybe use some cushioned orthotics, perhaps use a boot or a cast for a few weeks to decrease the inflammation and stop the pain, you might be able to convert some of the painful feet with tarsal coalitions to painless feet with tarsal coalitions. And there are 2 studies that say that you have about a 30 to 50% chance of eliminating pain in a painful tarsal coalition by doing one of these non-operative measures: activity modification, swim rather than play soccer, or swim rather than play cricket, use a soft orthotic or short leg cast or boot. But if those non-operative measures cannot relieve the pain in the 50 to 70% of cases, then that would be the indication for surgery. And as for surgery for painful tarsal coalitions, where you've not been able to eliminate the pain, one can resect the coalition and put something in there, interpose something to prevent it from growing back. Or you could perform a triple arthrodesis, or isolated hindfoot fusions, or osteotomies. And this is what Hitesh and Dhiren were talking about, is that there are potential options for treating the coalitions, but how to pick them has not been clearly identified or proven scientifically. But these are among the options that one could do. For the calcaneonavicular coalitions, there really is one surgical option, and that is if the pain cannot be relieved in a fibrocartilaginous calcaneonavicular coalition, resecting it is the way to go, with high reported success rates, even back to the 1940s. In order to see the coalition, one needs to reflect the extensor hallucis brevis from the sinus tarsi distally, exposing the connection between the calcaneus and the navicular, and that white line, in the small image, represents the synchondrosis. Here are some bones that were presented in a study where many cadaver bones were evaluated, and they found coalitions in about 13% of them, not all calcaneonavicular, but this is what the bone model looks like. The calcaneus and the navicular come together. It looks like a joint, but there should be no joint there, and most of us don't have a joint there. And if you look at it in that projection, looking straight on to the articular surfaces of the talus and the to the navicular and the cuboid, you can see a pseudo joint between them. Look how deep it is. When you're looking at it from the surface, it's maybe 1 centimeter from anterior to posterior, but when you're looking at it in this way, it's about 2.5 centimeters deep. It goes way, way down. You're not seeing the longest proportion when you're looking at it surgically or anatomically. And there can be different sizes, different connection patterns that this study that was published by Cooperman from Cleveland found that there are different connections. That's one of the reasons for getting the CT scan. Besides wanting to see if there's also a subtalar coalition, the CT scan also says in this particular calcaneonavicular coalition, how deep does it really go? Where is it exactly? Because when you're going to resect it, remove it, you need to have a roadmap in your mind. You cannot see exactly what you need to see when you're looking at it. Reflect the extensor brevis distally. Expose the bony connection. The white line is the synchondrosis. The two black lines represent the sites where the osteotomies will be performed to remove the segment of bone between the navicular and the calcaneus that includes the synchondrosis. You take small osteotomes that are inserted parallel with each other and parallel with the coalition and about 10 to 12 millimeters apart. And the bone fragment that is removed, and it was removed and then bisected, so you can see the navicular over the calcaneus, and that white line of cartilage is the synchondrosis of the calcaneonavicular coalition. That's the segment that came out. And it is important that the segment comes out as wide superficially as it does in the depth. The tendency is to make these bone cuts converge on the plantar aspect, and then you might remove most of the coalition, but not the very deep portion. Well, that's not a coalition resection. This piece that comes out has to be symmetric, as wide dorsally as it is plantarward. I drew that rectangular cube to show it might be 2.5 centimeters deep and maybe only 1 centimeter by 1 centimeter on the surface. And when it comes out, either in one piece or by using a kerosene rongeur to get the depth of the coalition removed, separate the two bones, not only superficially, but also in the deep, then what you're looking at is the spring calcaneonavicular ligament. The calcaneonavicular spring ligament. That's what you want to see to know that you've gotten the entire connection out as wide of a section, deep as superficial. You don't want to plunge through the spring ligament, so you have to be a little careful with how hard you're hitting your osteotomes, but you need to see the spring ligament. The hole should be pretty big. You can put either your index finger or your little finger in and confirm that the subtalar joint moves well, and confirm radiographically as well that there's no remaining connection between the calcaneus and the navicular. Then use some bone wax that you paint on the exposed bone surfaces, and take fat graft. I take it from the medial side of the knee. Some people take it from the buttocks and insert it in there because you want to resect the coalition, and you want to make sure that the bones, the exposed cancellous bone in both bones, doesn't say, oh, now I'm going to heal together. You want to prevent the two surfaces from seeing each other so they do not reform the coalition. Bone wax on the surfaces, fill with fat, and then put the extensor hallucis brevis back over the sinus tarsi where it began. For 2 weeks in a short leg non-wavering cast, scar tissue will form, help make sure that the fat graft stays in the cavity, and provide comfort. You just perform this operation. 2 weeks, let it settle down in a short leg non-weight-bearing cast. And then for the next 4 weeks, continue non-weight bearing, but begin active range of motion to get the comfortable motion back. And the reason I recommend 6 weeks of non-weight bearing is so that there is free movement, painless movement that's not exacerbated by weight bearing. After 6 weeks, all the postoperative pain is gone. The active and passive motion of the joint have been initiated, and then the child can gradually go back to activities. This is the way the images look on fluoroscopy, with one osteotome in place on the navicular side And then after resection, you can see the really white shadow confirming resection that you also see by direct observation. In some cases, the calcaneonavicular coalition is associated with a flat foot. Not as frequently as for the subtalar coalitions that we'll be talking about soon, but in some cases there's also a flat foot. The question is, if the pain is due to the coalition or due to the deformity. Because the deformity can be corrected, the flat foot deformity can be corrected with a calcaneal lengthening osteotomy, the flat foot reconstruction. It can work there. The calcaneonavicular coalition is all within the acetabulum pedis. It doesn't cross the subtalar joint. The only reason that these coalitions cause restriction of subtalar motion is because there's inflammation immediately adjacent to the subtalar joint, but not across the subtalar joint. So with these coalitions, calcaneonavicular, there's restriction of subtalar motion due to inflammatory pain, but not elimination of subtalar motion like there is in the subtalar coalitions that cross the joint. So if the deformity in these coalitions is the problem, not pain at the coalition site, one can perform a calcaneal lengthening osteotomy, flat foot reconstruction, and it works just like it does in a flexible flat foot. The osteotomy is proximal or posterior to the coalition. So the acetabulum pedis moves all together to align with the head of the talus. Well, what about doing coalition resection and deformity correction? Now, there's no data on this, but at least theoretically, I believe one should not do concurrent deformity correction and resection of a calcaneonavicular coalition. And here's the reason. You can see in the upper left and lower right, the dashed line would be an osteotomy for the coalition. On the navicular side, the short white line or black line are the cut on the calcaneal side. So boom, you resect the coalition. If you concurrently perform the calcaneal lengthening osteotomies, the long white and black lines, then that anterior calcaneal fragment is separated from its blood supply on two surfaces. Additionally, the fragment is smaller than normal, which could create instability in the calcaneocuboid joint. So between dysvascularity of the fragment, perhaps poor control of that fragment during calcaneal lengthening, I think it's not reasonable to perform the two at the same time. So if the child with this coalition has primarily pain, tenderness at the coalition, resect the coalition. And if the flat foot deformity becomes or remains an issue, after the first operation is healed, go back and correct the deformity. If, on the other hand, despite there being a coalition, the pain is due to the deformity, just correct the deformity, do the flat foot reconstruction, and leave the coalition alone. If the coalition is not the site of pain, if you also get an MRI and see no inflammation in the calcaneonavicular coalition, then leave it alone. 3/4 of people who have calcaneonavicular coalitions don't have pain. So you have to use the site of pain that I said was so important earlier in your algorithmic approach to how you manage these. In most cases, though, for calcaneonavicular painful coalitions that do not respond to non-operative treatment, you resect the coalition. As for the talocalcaneal or subtalar tarsal coalitions, here's the real debate. In 1948, Harrison Beath said that the management for painful talocalcaneal coalitions was triple arthrodesis, period. No other options, just triple arthrodesis. They recommended resecting the calcaneonavicular ones we just talked about. They said, yeah, you can resect those. But for these, they said pain, triple arthrodesis. In 1987, decades later, Scranton, an adult foot and ankle surgeon who actually happens to be from Seattle, found that he could resect some talocalcaneal coalitions and relieve their pain. Well, that was really good news because nobody had reported that before, that you can resect some coalitions, like you could resect all calcaneonavicular coalitions, but you could resect some of these and people would do well. He got some CT scans before the resections, and he concluded, without good data, but he concluded data-free, that one could successfully resect a subtalar coalition if the width of the coalition was less than the width of the subtalar of the posterior facet. So the width of the coalition in comparison with the posterior facet was less than 50%. Well, that sort of then became the new rule or law about what to do. If it was a small coalition, you resect it. If the coalition width was greater than 50% of the subtalar joint, then you should perform a triple arthrodesis. So it got us beyond Harris and Beath to say, yes, some can be resected, but as it turns out, the criteria for resection were not well described in that article. And in 1994, a group from Australia, led by Wild and Tirode, looked at CT scans more carefully, and they said you can, the two treatment options of resect the coalition or triple arthrodesis had to do with three features: the size of the coalition, not the width, but actually surface area, the health of the posterior facet, and the amount of valgus flatfoot hindfoot deformity. And this is a busy slide, but on the left are the resection criteria according to Wild and Tirode from Australia, and on the right, their criteria for triple arthrodesis. No middle ground, one or the other. It's kind of interesting to have three criteria and only have two treatment options, to think that if someone has a relatively small coalition, that they will always have a normal posterior facet and that they will always have minimal hindfoot valgus deformity, so that could be a resected coalition. Whereas if they had a very large surface area coalition, as on the right, it would always be associated with a narrow posterior facet and always associated with excessive hindfoot valgus, so one would perform a triple arthrodesis. There are so many flaws in this thinking. So the good thinking was both Scranton and Wild and Tirode said some subtalar coalitions can be resected. They don't all need a triple arthrodesis. But the flaw in all these studies was, how do you actually measure the size of the coalition? And number two is, what if all three criteria don't say either resect or triple? There's nothing in between. Well, I'm not going to go through all the next few slides in detail. I wrote a perspective article on this that was published in the Journal of Pediatric Orthopedic Society of North America this month. So Jay Posna has an article I wrote with Javi Masquillo from Argentina, and we described how all this focus on the size of the coalition makes no sense based on several things. We don't know the normal surface area or size relationship between a middle facet and a posterior facet in normal feet. I looked at every anatomy book I could find. Nobody knows what the normal size of a middle facet coalition is, or the relative size of the middle facet to the posterior facet. So how can we possibly know what normal is for a middle facet coalition? Plus, how do you measure the size of the middle facet? There on the left is a fairly uncommon horizontal coalition. So you can measure the coalition in the horizontal plane and say, wow, it's about as thick as the middle facet itself. But in the more typical downsloping coalition, do you measure that length, which is that projected horizontally, or do you measure the width of the coalition? They're not the same. So what do you measure? And how do you measure surface area in that? There's no surface, so you can't measure surface area. So I've already explained that this whole idea about measuring the coalition is challenging, perhaps completely inaccurate, but at the end of the day, why would it matter? What would seem to matter, if you're going to resect a coalition or not, would be how healthy is the posterior facet, the non-involved posterior facet. Once the coalition of the middle facet is gone, the sole weight bearing is on the posterior facet. And in fact, in a normal foot, of the three facets, the posterior facet does most of the weight bearing because it's the largest, most horizontal. So the health of the posterior facet would seem to be the primary indication for whether one should resect the middle facet coalition or do something else, not anything to do with the size of the middle facet coalition. So the argument goes further than that. The clinical definition of arthritis is joint pain. Arth means joint, itis means pain. So arthritis is joint pain. The radiographic definition of arthritis is joint space narrowing. You all know that when you're seeing adults who come in with pain at their hip or their knee, they have narrow joint spaces. The cartilage is thin, it's been eroded, it's been collapsed from trauma or from age. Radiographic definition of arthritis is joint space narrowing, perhaps with marginal osteophytes, perhaps with subchondral sclerosis, but joint space narrowing is the radiographic diagnosis. In some feet with middle facet tarsal coalitions, the posterior facet is thick and healthy, like the ankle joint, and in others it's narrow. Well, if the posterior facet in a foot with a middle facet coalition, if the posterior facet is narrow, it has radiographic arthritis by definition, but it doesn't hurt. A narrow posterior facet with a middle facet coalition doesn't hurt because it doesn't move. The top three images are coronal CT images in which the thickness of the posterior facet is about equivalent to the thickness of the ankle joint. So one could say radiographically, there's no arthritis, radiographic arthritis of the posterior facet. Whereas on the bottom, you could see that the thickness of the posterior facet is quite a bit narrower than the ankle joint. So if the ankle joint is the normal for what joint cartilage should be, and the posterior facet is thin, those on the bottom, those posterior facets have radiographic arthritis, but they don't hurt because they don't move. If you resect the coalitions of the middle facet in the top group, you would expect the posterior facet to be healthy, comfortable, move well, enable the activities that the individual wants and needs. Whereas if you resect the middle facet coalitions in the bottom group, you're going to convert radiographic arthritis to radiographic and clinical arthritis of the posterior facet. Again, it didn't hurt, but if you remove the middle facet coalition, these narrow arthritic joints that don't hurt will become narrow arthritic joints that do hurt. And what's the treatment for that? To fuse the subtalar joint. It was already effectively fused. So why would you resect the coalition in the group on the bottom only to create pain in sites that they didn't have pain, and the treatment for which is to fuse the joint that's already fused? So it doesn't make any sense to do that. It's the health and thickness of the posterior facet that should be the primary indication for resection versus either fusion or some other treatment. The other thing about the criteria for resection with with Wild and Terode, is that they talked about the amount of hindfoot deformity. How flat is the foot? We've all experienced that some middle facet talocalcaneal coalitions are resected and the feet get flatter. Well, they get flatter because the middle facet coalition is on the tension band side of the subtalar joint. So if that coalition is resected and there's a lot of hindfoot deformity, the flat foot will get flatter, taking away the tension band. So they identified, Wild and Terode identified, that the amount of deformity is important. They thought it had to do with resectability. It actually has to do with something else, and that is whether one should correct the flat foot deformity either concurrently or subsequently. The way they measured hindfoot valgus made no sense. It was not biological, it was not biomechanical. They picked some points, they drew a line, and it was nonsense. These are from their article. They picked points, they drew an angle from perpendicular, And they said that and they related the amount of valgus to whether one should correct deformity or whether one should fuse or not fuse. Well, that's an unreliable line. It varies from slice to slice in a CT scan, whereas had they chosen the anatomic calcaneus axis, which I drew in red, so that's the axis of the calcaneus, they would come up with a very different number, but one that's consistent from slice to slice within a CT scan. And so here, these are two slices, same foot, same CT scan, same day, and based on whether it's more anterior or posterior, you can see either more or less vertical height of the calcaneus. If you use the points that Wild used to draw the hindfoot angle, the angle is going to change or vary from slice to slice. Whereas if you use the anatomic calcaneal axis, it's the same no matter what slice you're using. So not only is the anatomic axis of the calcaneus reliable, reproducible, and doesn't change from slice to slice, it also gives you a very different number than Wild's angle for what they thought was too much calcaneal valgus. I have a study going on right now that we're going to show that using the anatomic axis of the calcaneus is not only reliable, but we're going to show what numbers would indicate too much valgus versus an okay amount of valgus that we don't need to worry about. So the size of the coalition doesn't matter. Clearly, it can't matter. The health of the posterior facet matters and should be used when you're considering whether to resect an intractably painful subtalar coalition or do something else. And the reason I said something else is, up until now, the two choices were resect the coalition or perform triple arthrodesis. Nothing in between. And we know that triple arthrodesis leads to degenerative arthritis of the ankle joint, and it takes away the shock absorbing function of the foot. So why would we want to do that? Another reason that we would not consider triple arthrodesis is, look at this x-ray. This child has an absolutely solid subtalar talocalcaneal tarsal coalition. Do you see that that looks like subtalar motion? And there's no subtalar motion. There's no change in the relationship between the tails and the calcaneus. But when under fluoroscopy, I so-called inverted and everted the subtalar joint, and what happened was that the calcaneocuboid joint on the lateral side of the image opened and closed. The navicular moved around the head of the talus, but it did so not by taking the acetabulum pedis with it. It moved around the head of the talus by distracting the calcaneocuboid joint while the subtalar joint didn't move. Well, this was a great adaptation, and I have many examples of this where the child with a solid subtalar coalition appears to have subtalar motion, but none exists. It's because Chopard's joints can develop hypermobility. Well, if you perform a triple arthrodesis, then you put all the stress on the ankle joint. If in this situation, you instead reorient the joints with deformity correcting osteotomy, which works just like it does in a flat foot, distal to the coalition, then you can preserve Chopard joints, correct deformity, relieve the pain due to the deformity. And that can be done either with or in place of resection. So here are the three management treatment options for intractably painful subtalar tarsal coalitions based on where's the pain, what's the deformity, how healthy is the posterior facet, how much deformity is. There are the three scenarios that you will see. So small group, tarsal coalition, you try to relieve the pain, it's not relieved, go to surgery. If the foot has a normal shape, like you can see there, no hindfoot valgus, a fibrocartilaginous middle facet coalition that's painful and not relieve the pain, A thick posterior facet. It's a normal facet that doesn't move and will not hurt after resection. Resect the coalition. Next scenario. It's a thick, healthy posterior facet. Means that if you resect the middle facet coalition, the posterior facet will be just fine and comfortable, but there's a lot of hindfoot valgus deformity. Resect the coalition because of the healthy posterior facet and correct the deformity concurrently with the calcaneal lengthening osteotomy, the flatfoot reconstruction. And the third scenario is a thick, osseous middle facet coalition, a narrow, not healthy posterior facet where you would not want to remove the coalition and create pain in this painless coalition. And the pain is not due to the coalition anyway, it's due to the deformity. Just correct the deformity. And calcaneal lengthening osteotomy in that foot works just as well as in a flexible flat foot. And since the pain is identical under the head of the talus, in the sinus tarsi, pain will be relieved and the deformity corrected. In all situations, if there's a tight heel cord till the entire triceps suri or the gastrocnemius, they should be lengthened. And those are the scenarios. So the message here is in subtalar coalitions, it's not about the size of the coalition. We have to get away from that concept. It was a false idol. It was a false target. The issue is not about the size. It's about the health of the posterior facet. Use that with determining to resect or not resect the coalition. And if there's deformity that is either the cause of pain or contributing to the pain, then either resect or don't resect the coalition and or correct the deformity. And I believe triple arthrodesis is never indicated in pediatric tarsal coalitions because they never have arthritis yet in the heel part or ankle joint. So that's the message. A lot of information. The two coalitions are both common, perhaps equally common. Understanding them is important. Understanding the non-operative management to start with. And then if we get to surgery, the algorithmic approach to surgery. So thank you for your attention.
Yeah, thank you, Vince. I would like to start with a question. The last point which you mentioned, when there is no movement at the subtalar joint, how lateral column lengthening will going to correct the hindfoot valgus?
It doesn't make any sense. All I can tell you is that it works. And the most important thing is aligning the tailnavicular joint. And the calcaneal lengthening osteotomy can realign the acetabulum pedis with both calcaneal navicular and subtalar coalitions, whether or not they're resected. It's because it separates the acetabulum pedis at the so-called neck of the calcaneus, and it moves the acetabulum pedis around to align the tailnavicular joint. What doesn't make sense, and I don't know how to account for it, is that the hindfoot valgus, which is posterior to the coalition, seems to go away. You don't see it anymore. So there's something about what's happening. I should have got, in my career, I should have gotten more CT scans, and hopefully others will, to say, we have the pre-op CT. We see the coronal image, and there's hindfoot valgus. And we see the naviculars out to the side, the eversion at the tail navicular. We see all that stuff. Why would it be that when we know we correct anterior to the coalition, the acetabulum pedis, why the hindfoot valgus goes away? But consistently, not 100% of the time, but almost 100% of the time, the hindfoot valgus goes away, even though the relationship between the posterior calcaneus and talus doesn't change. In some cases, though, and I write about this, you perform the deformity correction with the calcaneal lengthening osteotomy. You do all the other procedures, looking for forefoot supination, tight heel cord. You do all those things. Then, during surgery, you flex the hip, you have the knee flexed, and you see, is all the hindfoot valgus eliminated, or is there still some there? So I'd say, guess, 90% of the time, you don't see hindfoot valgus anymore. But 10% of the time, perhaps, you've aligned the tailnavicular joint, but there's still hindfoot valgus. Well, then put the leg back on the table and do a posterior calcaneal slide to get the rest of the valgus eliminated in the hindfoot. So the posterior calcaneal slide would be an add-on. It's not going to do anything that's already hasn't been done at the talonavicular joint, but if there's any clinical valgus remaining in the hindfoot, you can slide the calcaneus over.
Yeah. If anyone would like to ask question, please raise your hand so that. Yeah, Thomas, please.
Vince, what about the you said the fibrocartilaginous ones cause pain, but CT scan is not a great modality to pick up fibrocartilage, right? Is MRI a better modality for that, or will we still go with the CT?
If you know what you're looking for, the CT scan can identify fibrocartilaginous coalition. Some people have said, well, what about finding the fibrous coalition? Wouldn't that be hard on a CT scan? I've operated on dozens of coalitions, and everyone I've removed because of intractable pain has been cartilage. I think if we looked at it histologically under a microscope, it would be fibrocartilage and not cartilage in the sense of articular cartilage. But they're firm. They're not soft. They are firm cartilage, not bone, but definitely not mushy fibrous tissue. So on the CT scan, you look for narrowing of the joint. You look for irregularity. You look for subchondral sclerosis. I think if you know what you're looking for, and again, with more experience, you can see them, you can identify a coalition in the fibrocartilaginous phase. If you can't find in the fibrous phase, I don't think fibrous coalitions really hurt. But by the time they're fibrocartilaginous and they may cause pain, if you know what you're looking for, you can see it. The advantage of using CT scan is that for that amount of money alone, you identify the coalition, you identify the amount of hindfoot deformity, you identify the health of the posterior facet. So all the criteria you need for making your surgical decision are seen on the CT scan. The time I would use an MRI is if the pain pattern doesn't match what I see on X-ray or CT scan. If they hurt everywhere, or if they hurt in a place that's not typical for the coalition I'm seeing on the CT scan, I would get the MRI to say, is there something else going on? Does the child have complex regional pain syndrome? So look the MRI to look for pain that's not typical and doesn't match your findings. Or actually, here's one other or. In the feet that have both coalitions, both a calcaneal navicular and a talocalcaneal, and you're deciding, am I going to resect both of them? Which one is causing the pain? And sometimes you get an MRI scan and it shows that it's only one and the other doesn't light up at all on an MRI. And you say, okay, so I can ignore that one and just treat the painful one.
Yeah, John.
Yeah, so when you're doing the calcaneal lengthening osteotomy, do you always use bone graft, and where do you take it from? Because you're not doing a shortening on the opposite side here, are you?
So the calcaneal lengthening osteotomy is a technique and concept. What to put in the osteotomy is based on many factors. Some of them are religious, some of them are cultural, some of them are based on cost. So wherever you are in the world, you may have different reasons for using one or another. The graft must be cortical, it must be structural as well as have the ability to heal. And in a couple of, maybe next month, I think, Darren, I'm going to give a talk on exactly how to do the flatfoot reconstruction based on the calcaneal lengthening. But I'll preempt that by saying my choice for decades has been tricortical iliac crest allograft, because it has 3 cortices for structural stability. It has cancellous bone for rapid healing. One could use other types of bone grafts, allograft or autograft, and they have different advantages or disadvantages. So, for example, in some resource-challenged countries, docs use the fibula. Well, the fibula is primarily cortical bone. So it has structural ability to maintain separation of the fragments, but there's so little cancellous bone, it takes forever for the cortical bone to heal. And that's why iliac crest has enough cortex, but it also has enough cancellous bone to provide structure and also heal rapidly. And then there are choices of different either biologic or non-biologic materials that could be put in there, and they all have different risks and complications. Did that answer your question?
Yeah, so that's fine, because for us, usually getting iliac crest graft is not such a big deal. So for us, most people in India still accept that without a major issue. So getting a tricortical iliac crest graft is actually less problematic than taking a fibula graft, because every time you take a strut fibula graft, there's a potential morbidity attached to that. So
yeah,
if you can use
definitely. Yeah, it might not heal. The ankle might grow into valgus, but the real problem with the fibula, as I said, and I think you're saying too, is it has structural stability. It doesn't have the rapid healing
cancellous graft. Yeah.
Yeah, and if you use the child's iliac crest, it's only bicortical.
Yeah,
there's no cortex on the third side because the apophyseal cartilage is there. So if you take iliac crest from the child, it's 2 cortices. If you take it from the cadaver, it's 3. But again, I recognize differences in countries.
Yeah, and in the cerebral palsy, when we are doing a distal femur extension osteotomy, the segment of the femur can be cut and trimmed and then can be inserted into that graft. So in cerebral palsy, we use that also.
I'm sorry, I missed that, Darren. Say that again. If
Okay,
you take
see, like we carry out a lateral column lengthening in many of the cerebral palsy patient as a part of multi-level surgery. So when we are doing a distal femur shortening for correcting the knee flexion deformity, we remove the segment of femur.
A femur?
Yeah, femur for correction of the flexion deformity. And that segment of the femur, we use it.
Yeah. Oh, I see what you're saying. Yeah, well, it's a section of the femur, so it's corticocancellous. It has both types of bone. Yeah. As long as you have some structure and cancellous bone, that would be fine. Yeah, like I said, you have to be creative.
Yeah, Hitesh, please.
I have a question. How to diagnose the hypermobility of the chop part joint and how to treat that actually?
Okay.
What will you look for?
Yeah. So there were several points about hypermobility of Chopard's joints. And again, I have videos of kids who, in the second edition of my book, I'm having some links to videos, and some of them are these kids who have absolutely solid talocalcaneal subtalar joints, and they go from flat feet on the ground to heel raise, and they look just like flexible flat feet. And if you poorly examine subtalar motion, and instead of cupping the heel and moving it, you move the forefoot, they look like they have subtalar motion. You can see what I showed you in the talk were images taken in the operating room using mini fluoroscopy. So cut down on radiation for me, cut down on radiation for my staff, cut down on radiation for the child. Use mini fluoroscopy and move the forefoot inappropriately to try to demonstrate hindfoot motion. And then if you have the image looking down as an AP image, and you move the forefoot back and forth, you watch the calcaneocuboid joint open up like this. It's not supposed to open. The calcaneocuboid joint should have the same amount of motion as the navicular cuneiform joint, the cuneiform metatarsal joint, the cuneiform. They're potential joints, but they shouldn't move. But in some of these feet, with solid talocalcaneal coalitions, the calcaneocuboid joint goes from a potential joint to this. And when it does this, it allows the navicular and the whole acetabulum pedis from there forward to move around. So it looks like subtalar motion when it isn't. It's a great adaptation. I mean, the fact that some of these feet, and I think it's many of them, can develop hypermobility so that they look like they have flexible flat feet when they don't, is a protective adaptation preventing all the transferred motion to go to the ankle. So it doesn't all go to the ankle. Some of the stress transfer goes to the ankle, some goes to show part, so they both last longer. So that's the implication of all this. If they have that mobility, that why would you want to perform a triple arthrodesis and eliminate this incredible biologic adaptation that the body in these kids has done? Instead, allow them to maintain the hypermobility by doing deformity correction rather than triple arthrodesis.
Don't they also get more motion in the ankle joint when they have a subtalar coalition?
So the ankle, so again, this, and I mentioned this before, that I don't understand why, if God, if you will, why if you're given a tarsal coalition and you have no subtalar motion, why you have a 75% chance of not causing damage to your ankle joint. You know, why is that? Because we've known there's so many studies that if we do subtalar arthrodesis, if we perform triple arthrodesis, within about 15 years, the ankle joints are gone. They're wasted. So then you would say, if you're genetically programmed to have a subtalar coalition, does the ankle joint become a ball and socket? And the answer is, it doesn't look like it is. When I started the talk, I said I wasn't going to talk about the true subtalar coalitions, the synostoses that you see in fibular hemimelia, you see in hemiatrophy, where in those cases, the talus and the calcaneus were never separate. They never underwent apoptosis. So they were never separate bones. They never had fibrous tissue that became cartilage, that became bone, like in these. They just always had a cartilage joint that became osseous. Okay, so it's a different pathology. Well, in those cases, the subtalar synchondrosis, synostosis of the fibula hemimelia, of the hemiatrophy, they have ball and socket ankles, right? So if it starts at birth, you get a ball and socket ankle. Fantastic. But if you have these that eventually eliminate subtalar motion, you don't have a ball and socket ankle. I don't know why, but some things you just have to accept.
Okay, so we already have overshooted the time, but I request our fellows to understand the thinking process of Professor Mosca. Like, he's the one, I found him, like, every time he questioned the existing concept and then he tries to find out the reasoning. So it's not only to be a good surgeon, but equally it's important to have our own thinking. And today's lecture is a wonderful example of how one can think about and ask questions to the existing concept in the literature. So once again, thank you very much, Professor Mosca, for sparing your time and sharing your wide experience with our fellows. And I also thank OrthoTV for providing us a platform to spread the knowledge. So with that, I wish a good night and a good day to Professor Mosca, and see you soon for the 50th lecture on Mosca's procedure. Thank you.
Well, thank you very much. Again, my dear friends, I know we'll see each other again in the not too distant future and many more times. Thank you again for inviting me.
Okay, bye-bye.
Thank you. Good night.
Bye.
Good night.
Bye, Dhiral bhai.